Hello, everyone. Welcome to another Mainstream Mondays virtual morning report. During those sessions, we're hoping to talk about bread and butter topics, things you see on the wards every day. If anybody has a case, like regardless of how unique it is or how rare it is, please join us in presenting. If you open our website, clinicalproblemsolving.com, uh, and then you can just present a case from here. And let me start here. So you click on morning report. And then if you click on present a case, it asks you just for like a one-liner. And then once you click on it, somebody from our team will reach out and help you structure the case. So I encourage you to present cases, and you'll see today that literally any case is welcome. And I'm co-discussing with Lera today, who has been part of this community for a while now. She impresses me a lot with her clinical knowledge and her discussions and the ability to attend every single session. Lera, how are you today?
Hi everyone, I'm doing really, really good. I'm so excited because I learned a lot from all of you, but especially Youssef, because he's mastermind, especially in the bread and butter cases, which we're going to discuss today, and hopefully every Monday going on in the future.
So I'm excited too. And we want to hear from the people who are making this happen. Simi, you want to say hi to everyone?
Hi everyone, I just love Mainstream Mondays and very excited to describe today.
Yeah. And Sakith doing teaching points.
Hey everyone, I'm Sakir. I'll be doing the teaching points today. Super excited for the case.
Awesome. And lastly, Aaron, the person who's presenting more than one case on Mainstream Mondays. Aaron, do you want to tell folks about yourself, how you ended up in the academy too?
Yeah, sure. So I'm Aaron. I'm a medical graduate from the Philippines. I graduated last year in 2025. I'm currently working on my USMLE. I'm working on step two right now, and I'm currently doing a rotation in Hawaii. I guess I ended up on CPS by chance. I saw in a Facebook group, Bettina, one of our members, had posted to share cases. So I ended up presenting a case, just also a pretty straightforward case from my clerkship. And then I stayed for all the clinical reasoning and all of that. And I just had so many cases, and I learned that we can break down so many cases and learn so much from everything, even like the most simplest ones. So yeah, as Yusuf said, I encourage everyone as well to just share your cases. There's so much learning to be done.
Hawaii, Aaron. That sounds awesome. If
Yeah,
you're ready, yeah, that's great.
yeah. All right. So for the first aliquot, we have a 38-year-old male coming in for sudden onset of chest pain.
What a start. Um, I've been quite a lot and quite a lot about chest pain during the past week, and I think the sudden onset really makes me worried. And I would be just thinking there are many, many causes of chest pain, but at least for now, I would be most worried about something that can easily hurt the patient in the next 5 minutes rather than in the next 5 hours or 5 days or like 5 months. So I think something that I would be really worried about would be cardiovascular causes, something that can affect the heart, especially in the form of ACS. I think ACS is the top diagnosis, regardless of the age, the gender of the patient. Even young patients get ACS, maybe for different reasons, but they still can have it. And something that Dr. Smith usually tells is that one of the prognostically worst risk factors for a patient with ACS is the young age, because no one believes you that you can have an ACS. And I think I would be starting the workup with this differential in mind. And I think also the diagnostic workup for ACS is quite available everywhere, because all you need is basically to start is EKG and troponins and the patient's history, and you can go from there. Yeah.
I love it, Lira. And Lira, if this was like your friends calling you and they told you, "Hey, Lira, I have chest pain," what are the things that you tell them? Okay, go to the hospital.
I think I would just ask if they previously had something like this, or is this something new, and they feel if they calling me, potentially they feel that it's something new and it scares them. I would also be thinking what happened before the onset of chest pain, what triggered the chest pain, and basically how they feel. If they feel really, really bad, I would just tell them to go to the hospital. If they have some unexplained nausea, vomiting, diaphoresis, it sounds like a very alarming features to me.
Yeah, and so similar to you, I want to hear about the quality. So is it like substernal? Is it burning? Is it pressure like? I want to hear like where does it radiate? If it radiates to both arms or to the jaw, that has like the highest likelihood ratio for ACS. I want to hear if this happened before, like you said, and their past medical history, just to see the risk factors. I think we can start from there. I think in younger patients, like you said, the majority of cases are not going to be sinister, but we should assume the worst just to make sure we rule out the no misdiagnoses. But this could be just GERD, right? So I think it's important. Like these are the things we want to hear out for. Like what is the characteristics of the pain? Where does it radiate? And then try to take it from there. And then we can talk about, before we get to physical exam, we could talk about what maneuvers we want to do. Aaron, can't wait to hear more.
Yeah, sure. So, for further history, 2 hours prior to arrival, the patient noted sudden onset of chest pain. The chest pain was parasternal and non-radiating, and he described it as heaviness, rated at 10 out of 10 in severity. For what he was doing at the time, he was playing games at a casino. He denies any headache, nausea, vomiting, abdominal pain, difficulty breathing, diaphoresis, or any other complaint. 1 hour prior, he actually went to an urgent care where he was given pantoprazole and Pepto-Bismol without any relief of his symptoms. And since his symptoms persisted, he proceeded to the emergency department for further evaluation. So for his past medical history, he is hypertensive and dyslipidemic. His medicines that he has at home, but he says he does not take, are his telmisartan, carvedilol, and atorvastatin. For his family history, it's unremarkable. For his social history, he has no alcohol, tobacco, or drug use, but he states he's exposed to secondhand smoke since he works in the casino. I can stop here, or if you wanted me to go with the physical exam.
I think this is a good place to stop, just to like maximize the learning. Lira, what do you think?
Yeah, I'm still thinking and I'm worried about ACS in this patient. And basically what we have in mind when we think about ACS is not only like the current symptoms that the patient has, his state of EKG and trope diagnostically, but also something in the past, like risk factors for ACS and the probability of alternative diagnosis in this patient. And I think with this in mind, we have a few of the major risk factors for ACS in the form of hypertension and dyslipidemia. And one thing is that it's quite interesting to see such past medical history in a 38-year-old man, which is quite a young patient. But acutely, I think I would still be worried about ACS and waiting to see EKG and troponins for this patient.
Yeah, and would you expect the EKG to be positive, more likely to be positive if they're having chest pain, or if it's like intermittent?
I think I would be expecting some obvious changes if it's constant pain, but even when it's not present currently, we can still see some evidence of the process that something is going on here, like reperfusion T waves.
Yeah, that's what I was trying to allude to. So if like an EKG is a snapshot in time, and it captures what's happening in that moment. So if they're actively having chest pain, and if it is ACS, the likelihood that an EKG would be positive is more likely, as opposed to someone who has like intermittent pain, they're not having pain now, and then you get an EKG and it's normal. It doesn't necessarily rule out ACS. But if they're coming and having the pain now, you're more likely to catch something if it's ACS. So that's one thing to think of. And then, Lira, if you're thinking of like the framework we learn sometimes, like bad luck, bad genes, bad behavior, which of these can you like overlay on this case that would put this patient at risk? You already mentioned maybe bad genes. You said he maybe has a hypertension, dyslipidemia. What else can you think of that would put them at risk?
Yeah, I think if we think about just going from the groups like bad genes, we can think of something hereditary and not only vascular. I mean, potentially vascular, but basically what I think about here is fragility, something like poor vessel stability, predisposing him to dissections or predisposing him to the like bular rupture and pneumothorax development. Also something like bad luck. I don't think we can speculate much on it, but definitely can happen. In terms of kind of risky behavior, I would, in young patient especially with like in this setting that this patient is coming from, being in casino and stuff, I would definitely be thinking about some either emotional triggers that could potentially predispose to developing stress cardiomyopathy if it was quite a stressful experience for him, but also something like drug use and especially some stimulants like cocaine predisposing to vascular spasm as well.
I love that. And that's what I was trying to allude to as well. Like we know they have history of hypertension, dyslipidemia. That alone can cause you to be at risk for coronary artery disease. Another form of like bad genes, maybe they have an anomalous coronary artery, right? Maybe they just have like or bad luck, whichever category you put it. They might be at risk for coronary artery disease that is not apparent. They might have a genetic aortic disease, which we not apparent until this point. And then I like how you mentioned we want to look for like paraphernoid habitus. We want to look at their height. We want to look for any clues. So that's really good. And for exposures, where you're already thinking 2 steps ahead, could this be vasospasm? So could the patient be exposed to cocaine and now they're having vasospasm, and and that's the result of it is this chest pain, and it sounds persistent so far. Lera, I'm asking you a lot of questions. What exam maneuvers do you want to do? Because right now, like in real life, like sometimes when you're presenting, you say, "Oh, we just do everything." But to be like hypothesis-driven physical exam, what an exam could you do to calculate the risk of dissection, aortic disease, etc.? So, what is high yield for you?
I think the major thing here would be looking at the vitals. Basically, at the blood pressure, each and heart rate is what I'm really worried about. Also, something that, especially coming from the aorta hypothesis, we can check for pulses on both arms and blood pressure on both arms as well.
Yeah, I love that. This is exactly what I would do. Pulse exam, auscultation exam, like you said, checking for JVD, always like pretty reasonable. And then we'll take it from there. And then pulses, if the pulses are discriminate between the arms, that's predictive of like a dissection. If they're both there, you could still have a dissection. So it's not necessarily a sensitive test. In the past, we used to like go and press on the patient's chest and they're tender to palpation, so it must be costochondritis. That actually has a very poor likelihood ratio. So it's not a good test to do. So I no longer should do that, because even if they're having pain there, they could have like ACS or any other sinister etiology. So Aaron, excited to hear more.
Yeah, of course. So for the blood pressure, the patient's blood pressure was 180 over 100. The heart rate was 72. The respiratory rate was 21, and O2 was 100% on room air. The exam was otherwise unrevealing. The blood pressure was equal on both sides. Pulses were equal on both sides. CV exam was unremarkable. Regular rate and rhythm, no murmurs, no bruits. Pulses were good bilaterally for the lung exam, clear, no crackles or anything. Otherwise, unrevealing exam. I can pause here. I can give you guys the next part with the initial diagnostics.
Yeah, I think we can take the initial diagnostics.
Yeah, okay. So EKG was done, which she just only showed ST elevations in V2 and V3. Spot CBG was 122. The CBC had a hemoglobin of 16.5 with a WBC count of 15,240 with neutrophilic predominance. Platelets were 239. MCV was 83. Chemistries were otherwise normal, aside from a potassium of 2.7. Ionized calcium and magnesium were normal. LFTs were also done, which were normal. Chest x-ray was also normal, and the lipase was also normal.
Yeah, basically what I hear right now is that this patient is in the process of sympathetic activation basically what is coming from the blood pressure, which is sky high, acute neutrophilia, presumably acute neutrophilia, and hypokalemia, which can also be seen in the setting of sympathetic activation. And the tricky thing about sympathetic activation is you have no idea for how long it's going to be present and what's going to happen after the sympathetic crisis resolves. Is this patient going to be stable or go into the overshoot into the opposite direction?
Yeah, love that. That's a really, really advanced like thinking, Lira. Not a lot of people know about this. So I really commend you for learning all of this and just seeing like, oh wow, high blood pressure plus hypo-K, sympathetic activation. So that's a really, really good call. What are you making of the EKG? And yeah, and then Aaron, what was the protein you mentioned? And do we have the albumin? If not, it's okay.
Yeah, it was normal. The total protein was 7.96, albumin 4.7.
Okay.
Yeah, with the EKG, I don't have anything to add because like ST elevations in V2, V3 can be seen physiologically in healthy patients, especially in the absence of, at least we don't hear it, but in the absence of reciprocal changes. But in close proximity to it, if there is some ST elevation also present in lead V1, I would potentially be worried about posterior myocardial infarction. But since we don't hear it, I would still look for it. But if we don't hear it, I wouldn't pay too much attention to this EKG.
Yeah, and Lira, how do you explain like reciprocal changes if you have like a medical student with you on the team, or what are reciprocal changes?
Yeah, basically, I like to think of it, if there is something coming up, there is always something coming down. So there's always a balance on the EKG film.
Yeah, so basically, if you have the heart, and the EKG is measuring the vectors from all the side of the heart. So if the vector on one side, if you have a focal injury, on one side, the vector will be very positive, but if you check the vector from the other side, the exact opposite of it, it should be negative. And that's what reciprocal changes is. We're asking, is there a focal deficit? And that deficit will cause an EKG abnormality from this side. But if you check the opposite side, you should have the exact opposite abnormality because you're just checking the same axis. For those who hate physics, I apologize. So that's what reciprocal changes are. We're asking, is there a focal injury? And how can we have evidence that this is focal? By checking the other side, because this injury is transmitting across that entire axis. And if you have a reciprocal injury, that means you do have a focal injury in that location and causing the opposite reciprocal changes. And that's why we think of that with MI, because with MI, you have one portion that is injured versus with pericarditis, where you have diffuse ST elevations and you don't expect reciprocal changes because there is no focal injury. So thank you for sharing that, Lira. What would you do next?
I think I would still like to get a D-dimer just in case because it has quite a good negative predictive value, I think, for this action and also for PE, but I'm not so worried about this hypothesis here. Yeah, actually, I want to see what happens to the patient in the 5 minutes to understand what's going on here. Is this transient sympathetic crisis or is it progressing somewhere that I don't want it to be progressing?
Yeah, do you want a troponin?
I think I would get it, but I don't think we'll get a lot of information from it in this case because with this presentation, like with those abnormal vital signs indicating sympathetic crisis, I'm not so worried about ACS, but it kind of lower on my differential, but it still is here, and missing it would be quite a bad thing to happen. I
Exactly.
think
It's
if
one of
we,
those instances where like
yeah.
maybe the pretest probability is not high, but if it's positive, it will like significantly change your management, right? So I think a high sensitivity trope, if we get that and that's negative, I'll be reassured. Like, okay, this is probably not ACS, this is probably not a dissection, although the what the cardiologists say is that if the patient is having active chest pain, you should get more than one troponin just to see the trend, because if you capture just one, they might not capture the injury. So they want you to, if they're having active chest pain, you would get like 2 sets of troponin 1 to 3 hours apart, and that tells you that there's no like acute rise in the graph or the curve of the troponin to think about that. And then if it's negative, I would think less likely of like PE, like you said, less likely dissection may be still on the table, but not affecting the coronaries, and then taking it from there. And then maybe taking a history, seeing if they have any like, is it a sympathetic surge from a molecule that they ingested, or is it like internal? And I think taking more history and seeing where they progress will be helpful, maybe it's troponin. Any other thoughts, Leroy, or anything else you want?
Yeah, I think with those kind of unequivocal findings about ACS, we can also get a TTE just to get if there is some focal wall motion abnormality or if there is something else happening. Yeah.
Yeah, I agree. And then depending on where you are, you might affect how quickly you get a TTE. Like in some hospitals, it might be like more than a day. Well, like the troponin comes back in an hour. Well, the echo might be a while. But maybe getting an echo or doing yourself like focus if you're like trained in it. So that would be cool. Aaron, what happened next?
Yeah, so this patient actually, while he was sitting there in the ED, his BP kept going up with the blood pressure systolics was staying in the 200s. So he ended up getting a nicardipine drip. The ED actually also considered ACS with those SCA elevations. So he's loaded with dual antiplatelets and high dose statin. His trope eventually came back with, and it was 5.5, which was normal. They also gave him IV Tylenol and morphine with some improvement of his pain. So after that, they said, can we consider an intra-abdominal pathology? So they got a CT of the abdomen and pelvis. And if I could just get permission to share my screen, I'm going to share the CT.
Yeah, and while Aaron shares his screen, Lyra, do you remember the framework for sympathetic surge for acute rise in hypertension being either aldosterone or norepi? Do you remember that framework?
Yeah, I think I do. Like, basically, when we have acute hypertension, if we throw all the like details aside, we basically focus on two molecules, either aldosterone or catecholamines, and it depends on how much the acute hypertension leaves. If it's persistent, like in this patient, we would be more worried about aldosterone, and potentially persistently low potassium can also indicate this problem. I think I would still like to look, if I have the time or ability, to look at the previous BMPs of this patient. Was his potassium acutely low, which would still, I think, point more towards acute catecholamine surge, or was it persistently low, which can point me towards aldosterone? Yeah.
Yeah, and this is very, very advanced, like clinical reasoning, by the way, that most people don't have. But to reiterate what Lyra said, big categories for sympathetic surge: catecholamines and aldosterone. Catecholamines means something like I'm scared. I used cocaine. I have a pheo. These are all caused catecholamine excess. Aldosterone excess can be by an aldosterone secreting tumor, but can also be caused by an infarct to the abdomen or a stroke. So you know how in patients with stroke, they have very high blood pressure? So the infarct of the brain causes aldosterone excess. So these are the two big branches that you want to think of. This is catecholamine or aldosterone. And oftentimes one of these two often reveals the answer as to the very high blood pressure. So Lira, you're really impressing me. I think most people don't know this framework, and you should be proud of yourself. Aaron.
I'll play it. I'll play the video now. I'll just play it one more time.
And Aaron, if you want to pause at the window, and not this window, sorry, at the aorta. You're right there. Yeah, and Aaron, if you have the mouse, are you able to point to it on the screen for the people like watching? And if you see like the aorta has like a crescent in it, and can we go back to see where it started? Just to wow. Lera, what are your thoughts?
Yeah, I think we're right to not disregard the theory, the hypothesis of aortic dissection too fast in this patient. And I didn't cut clearly, was there also involvement of the ascending aorta or just descending, which can affect the management? But yeah.
So Aaron, what was the read?
Yeah, so for this read, since this was just a CT of the abdomen pelvis, they read it as an aortic dissection in the mid-thoracic aorta at the proximal descending thoracic aorta at the level T5 down to the renal bifurcation. So after that, they got a CT angio, and then the read for that was a aorta's normal configuration. A subtle crescentic hyperdensity is seen along the wall of the ascending aorta to the aortic arch, approximately 1.8 cm distal to the left subclavian artery, with a maximum thickness up to 1 cm, relating to a probable intramural hematoma. A dissecting intimal flap is detected with suggestive entry tear at the proximal thoracic descending aorta, about 1.8 cm distal to the left subclavian, while the exit tear is identified at the abdominal aorta renal artery level. And yeah, it was a acute aortic dissection, Stanford B. The Bakey 3 was the final read.
Wow. Lera, I would love to take your reflections, or what are you doing?
Yeah, I think I would just immediately want to start the patient on beta blockers to decrease the pressure on the dissection. And I'm mostly curious why this happened at such a young age. Yeah.
Yeah, it's really terrifying. I'm like you. I want to start like an Esmolol drip and then phoning a friend, right? Calling the vascular surgeons. There are more genes than Marfan. We know Marfan or Ehlers-Danlos, but there's more than one gene that cause collagen deficits that can sometimes present with dissection in young people. They are rare, but once they present, they're actually devastating. They're often very often present with medical error because, like Lera said in the beginning, you're young, you expect this less to be dangerous. In this case, the troponin was normal, right? And I don't know, Aaron, if we have a chest X-ray in the beginning or not, if we ever had that.
Yeah, it was normal. There's no mediastinal widening or anything there.
So 80% of cases show widening, but 20%, so 1 in 5 folks with dissection are going to have a normal X-ray. So imagine this patient comes into the ER, has normal X-ray, normal troponin. I can see a world where he gets discharged, right? It's a very like dangerous space where it can be risky. So I think it's very important to see if the patient is still having chest pain. So not let go of that. If they're actively having chest pain, you need to like, continue the workup. And in this case, we did find a dissection, which is terrifying. And I'll share a link for a community. There was a famous actor actually who died of a dissection at a young age, and it was a non-Marfan gene that caused it. So there's like an awareness website that I'll share about it. Aaron, what happened in this case?
Yeah, but we called CT Surge, and they agreed just medical management for this, and we just started IV esmolol, and he was just monitored, and eventually, yeah, it was just medical management throughout. Eventually, he got better and was discharged.
Any thoughts or reflections here?
Yeah, my biggest reflection is, Aaron, that keep presenting cases. We're never going to get tired of you. And um, I'm also learn from patients' behavior. And despite the like benign looking interior and basic labs, the patient came back with the chest pain, which should make us really worried that something bad is happening. And at least with this in mind, we should pursue at least more advanced imaging as happened in this patient. And I'm really glad it happened.
Yeah. Thank you so much, Lera. Aaron, any teaching points or reflections from your end?
I guess for me, one of the points I realized, which you already mentioned, is the patient's still in pain, and we still haven't really fully explained it. Why not get a further workup, especially since that was already what he was coming in for? He already went to the urgent care. He got a PPI there. That wasn't improving. The EKG, the trope was normal, but he still had some pain. So the ED still really believe that there was something there. So that's why they got the CT of the abdomen in the first place, which actually did find something significant. So I guess it's really the believing the pain.
Yeah, awesome. Thank you so much, Aaron. Sakif, can't wait to learn from you.
Yeah, thanks a lot for the amazing discussion. I'll just share three of the teaching points that stood out to me. So we learned that EKG basically captures only what happens in the moment. So the likelihood of EKG being positive is much higher in patients who are currently having an episode as opposed to patients having intermittent pain. And as in this patient, we saw that he had a high blood pressure and hypokalemia, and that should reflexively make you think of sympathetic activation. And then when you think about sympathetic activation, try to divide it into two main buckets, it being either aldosterone excess or catecholamine excess, and then from there on you can start thinking about all the other etiologies. And the last point would be 80% of patients with the aortic dissection have a mediastinal widening on chest X-ray, but 20% can have a completely normal chest X-ray as well. Thanks a lot for the amazing case here on.
All right. Thank you, everyone, for joining Mainstream Mondays. Have a wonderful day. See you soon.